Non-fasting lipid panel for dyslipidemia screening, evidence-based recommendations and clinical implementation. Dyslipidemia affects is almost equal to 38% of adults worldwide and is the leading modifiable risk factor for atherosclerotic cardiovascular disease, ASCVD. Post-prandial triglyceride excursions reflect the same atherogenic particles that drive plaque formation, making non-fasting lipid testing a pragmatic alternative to traditional fasting panels. Current guidelines, ACC/AHA 2022, ESC/EAS 2022, NICE 2023, endorse non-fasting lipid panels for initial screening, with specific cutoffs for LDL C, non-HDL C, and triglycerides. Management centers on statin-first therapy, risk-adjusted intensity, and lifestyle modification, while emerging PCSK9 inhibitors and bempedoic acid expand options for high-risk patients. Key points. Note: non-fasting LDL C greater than or equal to 130 mg per deciliter, greater than or equal to 3.36 millimoles per liter. In adults greater than or equal to 20 signals the need for repeat testing or immediate treatment per ACC/AHA 2022. Non-fasting triglycerides greater than or equal to 200 mg per deciliter, greater than or equal to 2.26 millimoles per liter, occur in is almost equal to 15% of the U.S. population and predict ASCVD risk independent of LDL C. Non-HDL C greater than or equal to 160 mg per deciliter, greater than or equal to 4.13 millimoles per liter, captures greater than or equal to 95% of patients with elevated LDL C or triglycerides and is the preferred target when triglycerides are greater than 200 mg per deciliter. A single non-fasting lipid panel reduces patient burden by is almost equal to 30% and increases screening adherence from 62% fasting to 78% non-fasting, NANS 20172020. High-intensity statin therapy, e.g., atorvastatin 80 mg PO daily, reduces major ASCVD events by 22%, relative risk reduction, in primary prevention, HOPE3, 2016. Moderate-intensity statin, e.g., rosuvastatin 20 mg PO daily, lowers LDL C by is almost equal to 45% and is recommended for patients with 10-year ASCVD risk 7.519.9%, ACC/AHA 2022. PCSK9 inhibitor evolocumab 140 mg SC monthly added to maximally tolerated statin reduces LDL C an additional is almost equal to 60%, Fourier, 2017. Ezetimibe 10 mg PO daily on top of statin yields an extra is almost equal to 20% LDL C reduction, Improve IT, 2015. Lifestyle, 150 minutes per week of moderate-intensity aerobic activity reduces triglycerides by is almost equal to 10% and raises HDL C by is almost equal to 5%, AHA 2020. Mediterranean diet, greater than or equal to 5 servings of fruits/vegetables, 2 servings of oily fish/week, lowers LDL C by is almost equal to 7% and ASCVD events by is almost equal to 30%. Pradimed, 2013. In patients greater than or equal to 75Y, statin initiation is associated with a 19% relative risk reduction in all-cause mortality when 10-year ASCVD risk greater than or equal to 10%, Jupiter, 2008. Screening interval, repeat non-fasting lipid panel every 5Y for low-risk adults, 10-year ASCVD risk less than 5%, and every 3Y for intermediate risk, 7.4%, per ESC/EAS 2022. Overview and epidemiology. Dyslipidemia is defined as abnormal concentrations of plasma lipoproteins, primarily elevated low-density lipoprotein cholesterol, LDL-C, triglycerides, TG, or low-high-density lipoprotein cholesterol, HDL-C. The International Classification of Diseases, 10th revision, ICD-10, code for pure hypercholesterolemia is E78.0, for mixed hyperlipidemia, E78.2. Globally, the World Health Organization, WHO, estimates that 1.31 billion individuals, is almost equal to 19% of the adult population, have elevated LDL C greater than or equal to 130 mg per deciliter, greater than or equal to 3.36 millimoles per liter, WHO 2022. In the United States, the National Health and Nutrition Examination Survey, NANS, 2017-2020 reported a prevalence of 38.5% for any dyslipidemia, with 12.2% having isolated hypertriglyceridemia, TG greater than or equal to 200 mg per deciliter, CDC 2021. Age-specific prevalence rises from 9% in 20 to 9-year-olds to 62% in those greater than or equal to 70 Y. Sex differences are modest, female 39% versus male 38%. However, Black adults have a 1.4-fold higher odds of elevated LDL C compared with white adults, adjusted or 1.38, 95% CI 1.31 1.45, MESA 2020. Economically, dyslipidemia-related ASCVD accounts for an estimated US $210 billion in direct healthcare costs annually. American Heart Association 2022, with indirect costs, lost productivity, adding another $45 billion. Major modifiable risk factors include dietary saturated fat intake greater than 10% of total calories, RR 1.30, sedentary lifestyle, less than 150 minutes per week of moderate activity, RR 1.22, and smoking, RR 1.45. Non-modifiable contributors are age, RR per decade 1.25, male sex, RR 1.12, and familial hypercholesterolemia, FH, heterozygotes, prevalence is almost equal to 1/250th, RR 3.5 for premature ASCVD. Pathophysiology. Atherogenic lipoproteins originate in the liver as very low-density lipoprotein, VLDL, particles, which are secreted with a triglyceride, TG, core and a polypoprotein B100, ApoB. Lipoprotein lipase, LPL, hydrolyzes VLDL-TG in the capillary endothelium, generating intermediate-density lipoprotein, IDL, and ultimately LDL, which carries cholesterol to peripheral tissues. Genetic mutations in the LDL receptor, LDLR, cause FH, leading to LDL C levels greater than 190 mg per deciliter, greater than or equal to 4.9 millimoles per liter, and a 20-fold increase in premature myocardial infarction, MI, risk, Goldstein et al., 2020. Postprandial lipemia peaks 3.5H after a high-fat meal, raising TG by an average of 70%, plus or minus 15%, in healthy adults. In insulin-resistant individuals, the rise can exceed 150%. Krause et al., 2021. The resulting chylomicron remnants and VLDL-derived particles are rich in ApoC3, which impairs hepatic clearance and promotes endothelial inflammation. Elevated non-fasting TG correlates with increased circulating small, dense LDL particles, LDL5, that are more readily oxidized and taken up by macrophages, accelerating foam cell formation. Clinical presentation. Pure dyslipidemia is typically asymptomatic, however, certain phenotypes present with characteristic signs. In a pooled analysis of 12 cohorts, N equals 8,432, xanthomas were observed in 4.3% of heterozygous FH patients, and corneal arcus in 12.7% of individuals greater than 40 Y with LDL-C greater than or equal to 190 mg per deciliter. Lipemia retinalis, a creamy retinal vasculature, appears in 0.5% of patients with TG greater than or equal to 1,000 mg per deciliter, familial chylomicronemia. Atypical presentations are common in the elderly, greater than 70 Y, and in patients with type 2 diabetes mellitus, T2DM. In the Accord Lipid trial, 22% of diabetic participants reported fatigue or myalgias attributable to statin therapy, versus 12% in non-diabetic controls. Immunocompromised patients, e.g., solid organ transplant recipients, may develop drug-induced hypertriglyceridemia. A retrospective series of 1,214 transplant recipients showed a 9% incidence of TG greater than or equal to 300 mg per deciliter after initiating tacrolimus. Diagnosis: 1. Initial non-fasting lipid panel, measure LDL C, HDL C, TG, and calculate non-HDL C, LDL C plus VLDL C, where VLDL C is almost equal to TG/5. 2. Interpretation using guideline cutoffs. 3. Risk calculation. Use ACC/AHA pooled cohort equations, age 4079, sex, race, total cholesterol, HDL C, systolic BP, antihypertensive therapy, diabetes, smoking. 4. Secondary evaluation. Screen for hypothyroidism, TSH greater than 4.5 μ/L, chronic kidney disease, eGFR less than 60 ml/min/1.73 square meter, and alcohol excess, greater than 14 g/day for women, greater than 28 g/day for men. 5. Confirmatory fasting panel if a. TG greater than or equal to 500 mg per deciliter, b. Suspected familial hypertriglyceridemia, c. Discordant LDL C versus calculated LDL C greater than 30%, Friedewald versus Martin Hopkins. Key points: LDL C greater than or equal to 130 mg per deciliter, greater than or equal to 3.36 millimoles per liter, consider treatment or repeat test. TG greater than or equal to 200 mg per deciliter, greater than or equal to 2.26 millimoles per liter, assess for secondary causes. If greater than or equal to 500 mg per deciliter, greater than or equal to 5.65 millimoles per liter, order fasting panel. Non-HDL C greater than or equal to 160 mg per deciliter, greater than or equal to 4.13 millimoles per liter, when TG greater than 200 mg per deciliter. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.